sir.
Definitely.
So today's agenda will be, there will be faculty presentation till 3:40, followed by a discussion on the same, and then we will start our case presentation by 4 p.m., followed by the discussion. Thank you for joining. So sir, we can start.
So today's subject is communication, and Dr. Biju Raghavan will be dealing that topic. And Dr. Biju Raghavan is a consultant in pain and palliative medicine at Rajagiri Hospital, and he was working in palliative care for the last 15 years. He has worked in various institutions, and one of his interests in palliative medicine is in communication. So please enjoy the session. Biju, over to you.
Just a minute, doctor is on a call. We'll just join in. Okay, over to Dr. Biju.
Good morning, everybody. Today's class is on medical communication skills. Can we have the next slide, please? So the question is why we should learn medical communication, and the possible answers would be next. For us, first and foremost, for us. For example, if we see a patient and we provide the best possible prescription for that patient. However, when the patient goes to the medical shop and shows the prescription, and
1 minute.
Yes, Sunil.
I think there is some echo from your microphone, so I think you can move little bit from the, move little bit away from the microphone. Biju, you have to move away from the microphone. Yeah, now speak. Okay, please continue, Biju. Biju, nothing can be heard.
Hello?
Yeah, now it's okay.
Okay, right. So as I was saying, you may have provided the best possible prescription for a patient's problem, and the patient takes that prescription and goes to the medical shop and can't afford to buy all the medicines as prescribed. The patient may buy some of them, and as a result will not get an expected improvement, and because of that the patient may not return back to you, and you may lose client loyalty. So if you were to understand what is their social background, financial background, one could have possibly given a more practical prescription rather than the best prescription. And the most practical prescription will take into account all the other relevant factors. And that will also provide a good outcome and will help you to retain client loyalty. For that, what was missing was a bit of communication. So for us, it is very important to have the client loyalty. It reduces stress, because of it develops good relationship, and as a result of the above, our professional achievements will be better. And I always tell people, learn communication skills for your own selfish reasons. And that is, you can have any more number of points in here, but that is the gist of the matter. It is good for us. It should, a good communicator saves time, energy, and effort in their day-to-day medical practice. So a good communicator does not waste time and does not you know put too much stress, because a good communicator knows how to communicate smart rather than hard. Next slide, please. For the patient and family also, as is to be expected, good communication reduces uncertainty. They will know how to go about things. It gives them a sense of direction of what path to take, and it helps them to plan ahead. Next slide. And it is also good for society at large, because most of the time we see that there are a lot of misconceptions and unrealistic expectations from us, and that is why we have many times a lot of friction between the public and medical professions. For example, uh, all of you are medical professionals, you know what percentage of diseases known to modern medicine are curable. uh, the fact is, very few. In the 2011 WHO report on the pattern of mortality says that in the developed countries, around 70% of the people died of non-communicable diseases. Only 30% people died of other diseases. Even in a developing country like ours, the majority of the people, 60%, die because of non-communicable diseases. For example, diabetes, hypertension, most of the other endocrine diseases, most of the neurological conditions, motor neuron diseases, Parkinson's, and dementias, respiratory disease like interstitial lung disease, COPD, cardiac problems, congestive cardiac failure. Look at the GI problems, Crohn's disease, irritable bowel syndrome, you name it. Most of the diseases are incurable to begin with. Most of the diseases known to modern medicine are incurable. At best, you can try to control them. But that is not what they teach us in medical colleges, do they? Or the only thing that they teach us is how to diagnose disease and how to treat disease. Diagnostics and therapeutics is what they teach us. They don't teach us symptomatology. They don't teach us psychology, and definitely they don't teach us communication skills. And as a result, we ourselves are very ignorant of what modern medicine can provide realistically. And since we ourselves are ignorant about our capabilities, it is natural to expect that the society at large will have unrealistic expectation. So a good communicator will always try to bridge this gap between expectation and reality. And that is in our interest, because the earlier we do it, the less friction we will have with public. And also good communication skills will also help in having a harmonious relationship between the society and medical profession at large. It is our responsibility as medical professionals to work uh, uh, towards each one of us becoming better communicators for all these reasons. Next slide. So there are many barriers to communication. For example, a lot of miscellaneous things like lack of privacy, a lot of physical barriers, noise distraction. For example, nowadays our mobile phone is a ubiquitous thing, and it was a barrier for me to start the class today, because I had a patient who demanded to speak to me straight right now. So I had to cater to him. So some of the things you can modify, some of the things you'll have to learn to live with. Next. Patient as a barrier. Many of the times our patient may be very timid in nature. They may feel they can't talk about their other non-medical issues with us. And sometimes the family members can be a barrier. They may prevent us from exploring the patient's concerns and insight. Sometimes the medical condition, for example, somebody with a stroke and dysarthria, aphasia, or deafness, a lot of other conditions can act as barriers to communication. Next. What about us? Can we be barriers? Can we behave in a way? For example, when we wear a uniform, our whole bearing may change. Our facial expression becomes more serious. We seldom smile at our patients and their families. And all of that, our appearance itself can be a big barrier to communication. While we are with our friends, And colleagues, we may be more, our face may be more gentle, we may smile and things like that. But the moment we are in our professional uniform or in a professional mode, we suddenly become very, very aloof, very, very expressionless, or sometimes our behavior can be in such a way that people will find it very difficult to approach us. Next. And then our attitude about communication skills. Since we don't learn basics of communication skills in our undergrad program, we don't understand the importance of it. And we say, oh, it's not important. I've got better things to do. I don't have time for these kind of things. So our attitude can be a problem. Next. Our aptitude, since we don't get trained, it is just a matter of having some kind of awareness and training. But since we don't have it, we have a negative way of looking at things. What if they ask difficult questions? What if I don't have the answers? Many times we feel there's a lot of shame if we don't know the answers. But just saying that I really don't know about it, but I'll try to find it, makes us more humane, and the patient and family are better able to have a relationship with us if we show them that we don't have the answers for everything, but we'll help them out nevertheless. Yes, next slide. And as I earlier said, the lack of training, how do we reveal a bad diagnosis, and what if the patient doesn't want us to reveal it to the patient? What if the family does not want us to reveal to the patient? Then what do I do? Go on, next. And what if they get angry? What if they start crying? So many of the times when this kind of situation comes up, we don't know what to do, and many of times it is our own emotional insecurity which prevents us from uh, having a better communication. For example, most of us are told either go back to the slide, please. Most of us are told that we have to be strong for the patient, and that means are emotional. Then how do you expect us to be able to provide strength to the patient who is crying or the family who is crying? So the simple answer is, suppose if uh, if you, one of you, God forbid, your heart was broken and you are very sad and you wanted to share your grief with somebody, and if I give you two options, one option would be a robot, the other option is a human being, what would you prefer? How many of you would prefer a robot? Raise your hand. How many of you would prefer a human being? Raise your hand. Yeah, so most of you would prefer a human being. Now, the difference between a robot and a human being is a human being has emotions, right? And we as human being can connect to another human being only because we can connect emotionally. So if we don't behave like a human being and we are always very stoic and have a very stern face and not so much of emotion, our patient and family will not connect with us. They will not feel that, oh, here is a nice person, or here's a sympathetic person, or somebody who has empathy for us. And another thing is why we don't have emotional, we have emotional insecurity because we may be emotionally weak. For example, somebody who goes to the gym and builds a lot of muscles would usually wear small clothes to show off the muscles, because that person is not ashamed of the physique. Similarly, somebody who is not ashamed of their emotion will not be ashamed to show their emotion to the patient or the family or to anybody else in the world. Only those who are emotionally strong will show their emotions. So it is perfectly all right to to have an emotional relationship with your patient and family. It is not going to take a toll on you. If you have an emotional relationship with your patient and family, that will in no way impair your intellectual judgment of the patient care part. And having been in this field for 15 years, I can vouch for it. We can be emotionally attached. At the same time, we can be very, very intellectually, involved in the patient's care plan, and that does one does not contradict the other. Next slide. And then there are some distancing tactics we medical professionals adopt. Uh, let's take the slide forward. So a lot of them are non-verbal, poor eye contact. We deliberately avoid making eye contact because if you make eye contact, then they will come to you and ask for some favors and requests, and also why bother? Don't make any eye contact. And then maybe busy, but it's also true that many times we end up showing we are busy by looking at the watch or focusing on the case sheet, and and our facial expressions also sometimes show that we are very busy, or sometimes unfortunately some of us show our irritation on our face to the patient and family. And the same goes for the tone. uh, for example, somebody took discharge at a request and unfortunately had to come back, and if you were to greet them with the tone of, oh, you came back, huh? So that kind of a tone can be very, very discouraging for a person. And sometimes we bring anger in our voice. We may not raise our voice, but the tone of our voice, or the content of our voice, or the content of our speech may be something which will produce a distance between the patient and us. So a lot of non-verbal distancing tactics we medical professionals are known to make. Next. And sometimes when we categorize people, it's sometimes the when there's a change of uh, duty, sometimes the handing over, taking over is that bed number so and so is a scratch. And the moment you have that judgment labeled on a person, and that is how you are going to look at that patient, that patient is a scratch. And or that patient is a VIP patient. That is again another label that we usually put. Or sometimes we put a label that, oh, the patient's bystander is a doctor, god forbid, right? So many of these kind of labeling creates a distance between us and them, including the words us and them. Next line. Next slide. And then here, can we go back? And then there is this selective, paying selective attention, the things that you are comfortable with. For example, an example is that patient saying, doctor, I'm so worried, I can't sleep properly, I also have pain in the back. So instead of exploring the sleep, which will again bring up a lot of emotional issues or other things, just focus on things which we are comfortable about. So tell me about the pain. That kind of a selective attention to things that we are comfortable with, and not looking at the things that either we are not comfortable asking, or is likely to take us a lot of time. For example, I don't know how many of you ask the patient's spouse whether they are having food on time, whether they are sleeping on time. Anybody in this group asking that as a regular routine? Raise your hands. If you ask the patient's spouse whether they are taking food on time, or whether they are able to sleep. Anybody ask that as a routine? Nobody? Yeah. So sometimes you may feel that none of my concern is only the patient. Not true. We as doctors, we are supposed to be friend, guide, and philosopher to the patient and the family. We are not just a bearer in a hotel giving choices of medical options to the patient. Neither are we prescription vending machines. We are much, much more than that. Next slide. So that was one of the examples that I was talking about. We have to go beyond the physical part. How are you feeling? How have you been coping? And you'll be surprised by the response you get. And you'll be even more surprised by the goodwill you are going to generate by just asking few additional questions, not the conventional things that we learned in our third year MBBS, the history taking. Go beyond the history taking. Next slide. And again, leading questions is something that we very often do. You're getting better, isn't it? Your pain is better, isn't it? That isn't it kind of a thing is something uh, what what we call as a leading question, because you are basically leading the patient to give an answer that you want to hear. That patient, poor thing, may be forced to give you that answer, but that may not be the truth. And when we ask leading question, there's a real chance of we getting an answer and we getting misled by that answer. Always ask an open-ended question. How are you today? And then that person will be able to give you a question of how he is feeling today. So when we ask a leading question, it can lead to trouble. It can give you an answer that you want to hear, but that may not be the truth. And also, as much as possible, avoid closed questions, because that will end up giving you only a yes or no answer, will not give you a more elaborate answer. And remember, the more information you have, the more the better management you will be able to provide, because information is power. Next slide. Premature normalization. The moment somebody starts saying something sad or something, oh, I'm feeling so scared, or I'm so worried, or I'm so anxious, anything of that nature, out comes an assuring statement, just as if somebody has pushed a button in your body and out comes a good nice statement. Don't do that. Always ask what is causing you anxiety, what is scaring you, what is worrying you, and then they will come out with answers as to why they said what they said. And many times you will realize that, okay, this patient who has got CA ovary is worried that how will I marry off my daughter. And if you were to say in the beginning, it's a don't worry, I am there for you, I will take care of all your problems, will you marry her daughter off? So there can be a lot of problems by jumping to premature normalization or premature assurance. Don't do that. Find out what they're worried about and listen to them. When you listen to their problem, it may be that you really don't have an answer or you don't have a solution, but just the fact that you listen can be healing. Don't do something all the time. Be there. Being there is the important part. Next slide. Next slide. And sometimes we end up telling lies to our patient. CA cancer, CA stomach, multiple metastasis. We tell them, don't worry, there's an ulcer. Everything will be all right. So that lying, see, if you can't tell the truth, at least don't lie. Right? There's a big gray area between telling the truth and telling a lie. And we have to learn how to use that gray area, which lies between the truth and lie. If you can't tell the truth, at least don't lie and learn to use words which you can buy time for. Next slide. And having a sense of humor is good. No, I mean, nobody will deny that. But many a times what happens in despite the good intention in our heart, we may sometimes end up hurting the patient. And there have been many instances where instead of laughing with the patient or family, we have ended up laughing at them. And that can be very, very traumatic. I'm sure none of the doctors mean it to harm, but sometimes if our sense of humor may turn out to be appropriate, by all means bring humor, but the thumb rule is laugh with them, don't laugh at them. Next slide. And well, some people just speak so much that it's very difficult for the patient or family to bring in a question or a suggestion in between. And some people speak so little, it is so distressing that the patient and family say something and this person in front is not speaking much at all. So all of those things can also create a distance. Next slide. So what are the benefits of good communication? There could be clarity about the disease and treatment, better compliance with the treatment. Next slide. And very, very important, harmonious relationship. We are all very worried about how the way the relationship between public, the community, and the medical profession is deteriorating by the day. Every day we get to see so many, either newspapers or WhatsApp messages or videos on how our colleagues, both medical, I mean doctors, nurses, and other in the hospital are getting beaten up. The hospital is getting burnt and vandalized. All of these things are very distressing. We need to take the initiative in changing these things. And I'm not saying the whole solution is in us becoming better communicators. There has to be a lot of things to come together, but definitely one of the things that onus is on us is to become better communicators, learn good communication skills, participate in workshops on communication skills, and you will see that in small way we will be able to change our relationship with society. It will be a more harmonious relationship. It cannot happen in one day. It has to be a long process, and unfortunately we are the recipients of bad what do you call mentoring uh, from our teachers. They taught us pathology and microbiology. They didn't teach us communication skills. So that is the problem. And uh, and if we are good communicators, the patient and family will not leave us. They will always be with us, and this problem of hospital hopping and doctor shopping can be reduced. We can improve on client loyalty with good communication. Yes, next slide. And yes, gone are the days of a high and mighty doctor at a high pedestal and taking care of all the decisions. Nowadays, it's a teamwork, and for that we all need to be less paternalistic in our approach, and be genuinely, be able to see our other colleagues, the nurses, physiotherapists, or the clinical pharmacist, the dietitian, uh, social workers, all of them as equal. They all bring their domains, uh, specialty, there into the on the table. If we are good at the medical part of it, they are good at what they bring. So we all need to think of our colleagues not just in our other medical specialty but in other streams of healthcare as equal to us, and give them the due respect and take their opinions into consideration. And it is best to have a teamwork where all the consensus are taken, where before we provide the patient and family medical management options. Next. And of course, yes, we need to upgrade our skills so that we are able to better confront stressful situations. We need to know how to deal with an angry person. We need to know how to deal with somebody who is crying. We need to learn how to communicate bad news, how to manage pollution. All of these things are very, very important, and we need to learn all of that. Yes, next slide. And yes, the basics of good communication is active listening. It is a very, very dynamic process, and active listening is important for better history taking. Active listening can be adjuvant therapy, or sometimes active listening may be the main therapy. So, active listening can have diagnostic purposes as well as therapeutic purposes. Next slide. And very important to learn time management. We doctors are taught time management in medicine only in one context, that is in case there is a crisis, if there is a mass casualty or something like that, we know how to do a triaging, and triaging instantly makes us think, oh, this is how. But that is essentially time management. It is not just one person who takes care of 100 patients who is brought into the emergency. It is how you distribute your work among the medical professionals, and time management is the best utilization of your time, and also distribution of the work so that other people are also able to contribute. The same thing applies in communication. So we all need to get trained in communication so that we are good in managing our time. I remember I told in the beginning itself, somebody who is good in communication saves time, not spends more time on communication. And we will also learn how to create a conducive environment for good communication. Next slide. So just for our medical colleagues who are used to more of the clinical presentations, here's a bit of pathophysiology of communication. Communications like tumors may be benign or malignant, and they may also be invasive, and the effect of bad communication to the patient may metastasize to the family or vice versa. Next slide. And truth is one of the most powerful therapeutic agents available to us, but we need to develop a proper understanding of its clinical usage optimum timing, and dosage. Remember, I told you, even if you can't tell the truth, at least don't lie. And there's a gray area. But we should always try to be truthful to our patient, because no relationship can survive on falsehood. And if you're truthful to the patient and the family, and you'll remember what I said earlier, there'll be client loyalty. When you're truthful to somebody, they will have a client loyalty to you, right? So it is very important, but we should know how to tell the truth. We have how to, when to tell, what to tell, how to tell, and how sensitively to put delicate truths. So that is something we need to learn. Next. And if you are not understood even anything from the first slide till the last one, please understand that communication is a learned skill. It is not an inborn talent. If you want to sing on stage, God has to be kind on you. But you don't have to be born with a talent to be a doctor. You just need to get an opportunity and work very hard when you get an opportunity, and you can be a doctor, because that is a skill that we all learn. Similarly, medical communication is just a skill. Doesn't matter what is your personality. You may be an introvert or an extrovert. You may be a linguist. You may know 10 languages, or you may be struggling with one. Doesn't matter. All of us can be good communicators, because if we just work hard, we can all learn the skills in medical communication. With that, I stop. It is 3:40 at my end. I think we will have some time for questions and all. So I open the floor. Sunil, would you like to start with any comments?
Thank you, Biju. So that was all about communication in general. So we started with advantages of communication. Who is in most advantage regarding communication? Is it patients, professionals, or society? And the last word is, it is for us. The communication will be most advantageous for us health professionals. So if you look at the practicing medical practitioners, there will be two types where you will see maximum of patients. One will be the physicians, or professionals, where they have very good knowledge, and they are very good in academics. So many patients will go to them. But when you look at another group, then there will be the doctors with very good communication skills. Even though they are not academically very high-fi, then also if you properly communicate, these are the two groups where the maximum of patients go. So I think if you can properly communicate with the patient, it is a very good advantage for us. Then we can also remove many misconceptions of the society. And usually when the patients comes, they will tell us, no, that doctor didn't tell me anything regarding the diagnosis. So that may not be completely true, but there will be some truth in it. So it is important for us to properly communicate. Then Biju went on to say that there are many barriers in communication, and he divided it into environmental barriers, barriers from the professionals like us, and then barriers from the patients. Then we discussed about the distancing tactics. So this distancing tactics is not for us to practice, but for us to understand that these are the some tactics used by the medical professionals to avoid proper communication. So you can see in communication, most of the things can be done non-verbally. And if there is poor eye contact while you consult a patient, and if you look at somewhere else without looking at the patient's face, then the patient will not be interested. Next time you are going to lose the patient. And you can make the patient understand that you are very busy, maybe looking at the watch, or doing something else, or you are looking at the door expecting somebody is coming, or you are expecting somebody. Yeah, Vijay is looking at the watch, so he says he is busy. Okay, and even tone of voice, it need not be very loud. It can be very soft words also. So all non-verbal aspects of communication are very important, and it is said that most of the communication happens non-verbally. Maybe more than 80% of the communication happens non-verbally. When we talk, there are many non-verbal communication going on with your hands, face, eyes. So all these are non-verbal communications. And in the distancing tactics, there are many things like labeling the patient as a case. Um, then there may be other things like usually what happens is doctors want to focus only on the physical aspects, not on the other soft aspects like did you sleep, or when the patient cries, why did you cry? Instead of that, doctor may ask, what is your tell me about your pain or your um, breathlessness, so that it is easy to manage. But if the patient cries, then how are we going to manage? All these are problems with lack of training. Uh, then this is very important. That is, don't ask leading questions. Leading questions are those questions which would lead the patient to the answer that you would like to get. So you can see your pain is better, isn't it? So you are leading the patient to say that yes, I have pain relief. Most of the patients will be like this, but occasionally one patient may say no. So, but never ask leading questions. And close questions, sometimes you might have to ask if you don't get the proper answers. And premature normalization and false reassurance, all this should not be done because we won't know what the patient is really talking about. So if you say don't worry, then we will not understand why the patient is worrying or what is the problem that patient is worried. Um, so these are some distancing tactics that we have to avoid. And if you are a good communicator, it really takes less time compared to a person who has don't know how to communicate with the patient. So this is in short what Biju has been trying to tell you, and you can ask any doubts.
Just raise your hand.
Nihita.
Sir, there was a slide showing how to reveal, two questions were there, how to reveal a bad diagnosis. Another one was, I think, how to tell a diagnosis to the patient when the bystanders, when the caregivers are requesting not to reveal it to the patient. In these conditions, what we can do, can you explain, sir?
Okay. Biju, we have another session on pollution and communicating bad news, isn't it? So Nihita, we have it in detail in next session. So shall we talk it regarding the next session?
Okay, sir.
Yeah, I think it's on 5th. That session is on 5th, if I'm not mistaken.
Yes, sir.
Yeah, next Tuesday.
So we will deal with that on the next session.
Anything else?
Sir,
Yeah.
in the distance in tax, we also discussed some premature normalization.
Yeah.
Sir. Sir, can you explain it once more?
Biju?
Okay, right. So when somebody starts saying, uh, "Oh, I'm so worried," let us imagine this person has got, let's say, a bad disease. Okay. You can imagine anything, any disease, and the person knows about it. And when you have gone to see this person, that person says, "So I'm so worried," and we will assume that this person is worried about the disease, and we will, probably tell this person, "Oh, don't worry, we'll take good care of you." Anybody in your position would feel the same. uh, like there's one very common example of telling them, uh, are all of you conversant with Malayalam? Are all of you?
Yes, yes.
Yes, sir.
ഓക്കെ, ഓൾ റൈറ്റ്. സോ വളരെ കോമൺ ആയിട്ട് കേൾക്കുന്നതാണ്, നിങ്ങൾക്ക് കഷ്ടപ്പാട് കാണണമെന്നുണ്ടെങ്കിൽ RCCയിൽ പോയിട്ട് അവിടുത്തെ വാർഡിലൊക്കെ ഒന്ന് കറങ്ങി വരൂ, അപ്പൊ നിങ്ങൾക്ക് കാണുമ്പോൾ അറിയാൻ പറ്റും കഷ്ടപ്പാട് എന്താണെന്ന്. അപ്പൊ സത്യാവസ്ഥ എന്താന്ന് വെച്ചാൽ, നമുക്ക് ഒരു ബുദ്ധിമുട്ട് അനുഭവപ്പെടുമ്പോൾ അത് ലോകത്തെ ഏറ്റവും വലിയ ബുദ്ധിമുട്ട് അതായിരിക്കും. വേറെ RCCയില് വാർഡില് ചെറിയ പിള്ളേര് കഷ്ടപ്പെടുന്നത്, അതൊക്കെ നമ്മളെ സംബന്ധിച്ചോളം ശരി, അതൊക്കെ ഉണ്ട്. പക്ഷെ എന്റെ പ്രശ്നം ആണ് എന്റെ ഏറ്റവും വലിയ പ്രശ്നം. അത് കഴിഞ്ഞിട്ടുള്ളൂ ലോകത്ത് ബാക്കി ആരുടെയും പ്രശ്നം. അപ്പൊ എന്റെ അടുത്ത് നിങ്ങളൊന്ന് പറഞ്ഞോ, കുഴപ്പമൊന്നുമില്ല, എങ്ങനെയൊക്കെ ഒന്നും എന്താ പറയുക, അങ്ങനെ പേടിക്കേണ്ടെന്ന് കാര്യമില്ല, അല്ലെങ്കിൽ ഇങ്ങനെ എത്രയും നിങ്ങൾ ടെൻഷൻ അടിക്കേണ്ട കാര്യമൊന്നുമില്ല, അവിടെയൊക്കെ പോയി നോക്കൂ, അവിടെയൊക്കെയാണ് ആൾക്കാർ കഷ്ടപ്പെടുന്നത്. അപ്പൊ എന്റെ പ്രശ്നം നിങ്ങൾ ലഘൂകരിക്കുകയാണ്. ഞാൻ ഇത്രയും വലിയ ഒരു പ്രശ്നം ചുമന്ന് നടക്കുന്നുണ്ട്, എനിക്ക് അതാണ് എൻ്റെ ഫോക്കസ്. അപ്പൊ അത് നിങ്ങൾ എൻ്റെ ആ ഒരു കാഴ്ചപ്പാടിനെ നിങ്ങൾ നിഷേധിക്കുകയാണ്. അത് അത്ര വലിയ സംഭവമല്ല എന്നുള്ള രീതിയിലുള്ള വാക്ക്, അല്ലെങ്കിൽ ആ രീതിയിലാണ് നിങ്ങൾ എന്നെ സമീപിക്കണമെങ്കിൽ എനിക്ക് തീർച്ചയായിട്ടും നിങ്ങളുടെ അടുത്ത് ഒരു തൃപ്തി ഉണ്ടാവില്ല. ഐ വിൽ നോട്ട് ഫീൽ സാറ്റിസ്ഫൈഡ് അറ്റ് ഓൾ വിത്ത്. നിങ്ങൾ നല്ല മരുന്നൊക്കെ എനിക്ക് തരുന്നുണ്ടാവും, പക്ഷെ നിങ്ങളുടെ സമീപനം എനിക്ക് തീർച്ചയായിട്ടും ഒരു തൃപ്തികരമല്ലായിട്ട് എനിക്ക് തോന്നുന്നു. അതുകൊണ്ടാണ് ഒരു വ്യക്തി അവരുടെ ബുദ്ധിമുട്ട് പറയുമ്പോൾ അതിന് നമ്മുടെ ഫുൾ ഫോക്കസ് അതിന്റെ മുകളിലായിരിക്കണം. അല്ലാതെ വേറെ ആള് ഇതേ അവസ്ഥയിൽ വേറെ ആള് ഇത്രയൊന്നും വേദന ഉണ്ടാക്കണില്ലല്ലോ, ഇത്രയൊന്നും വേദന പറയണില്ലല്ലോ. നമ്മുടെ കാനല നോക്കൂ, 18 ഫ്രഞ്ച് ഗേജ് ആണ്. ഈ കാനല കൊണ്ട് ആ കിടക്കുന്ന വ്യക്തിക്ക് നോക്കൂ, നിങ്ങളെ പോലെ ഇത്രയും ബഹളം ഉണ്ടാക്കണില്ലല്ലോ. അങ്ങനെയൊക്കെ എന്റെ ബുദ്ധിമുട്ടിന് നിങ്ങൾ വേറൊരു ആളായിട്ട് താരതമ്യപ്പെടുത്തിയിട്ട് എന്റെ ബുദ്ധിമുട്ട് അത്ര വലിയ സംഭവമൊന്നുമല്ല, ഇതൊക്കെയൊക്കെ സാധാരണയാണ്, അങ്ങനെ ആ രീതിയിൽ അത് ലഘൂകരിക്കാൻ നോക്കുമ്പോൾ എനിക്ക് തീർച്ചയായിട്ടും തൃപ്തിയില്ലായ്മ ഉണ്ടാവും. അതുകൊണ്ട് നമ്മുടെ ഇടയിലുള്ള ബന്ധത്തിനെയും അത് ബാധിക്കും.
Nida, I will tell you an example. Suppose ഒരു കയ്യിലെ ഒരു ഇഞ്ചുറി പറ്റി, and you have pain, you are going to a casualty, and you are crying because of pain. But at the same time, there is a patient nearby you who has cancer and he has very severe pain. And then, or a patient who suffered a road traffic accident and has fracture, a big wound, and the doctor comes to you and tell you that, Nida, why are you crying? അപ്പുറത്ത് കിടക്കുന്ന പേഷ്യന്റ് കണ്ടില്ലേ, ഇത്രയും വലിയ മുറിവൊക്കെ ആയിട്ട് അനങ്ങാതെ കിടക്കും, നീതയ്ക്ക് ഒരു ചെറിയ ഉണ്ടല്ലേ ഉള്ളൂ, ഇത് അത്രയും കരയേണ്ട കാര്യമൊന്നുമില്ല. അത് കേട്ടപ്പോ നീതയ്ക്ക് സന്തോഷമായോ? നീതയ്ക്ക് ഒരു ചെറിയ മുറിവേ ഉള്ളൂ, പക്ഷെ അപ്പുറത്ത് കിടക്കുന്ന ആൾക്ക് ഭയങ്കര വലിയ മുറിവാണ്. എന്നിട്ട് ആള് കിടക്കണുണ്ടോ, നീത എന്തിനാ കരയണം? അപ്പൊ doctor is trying to compare you with that another person. So that is what premature normalization, or premature, it is premature normalization.
Thank you, sir.
നമ്മളെ ഹാപ്പി അല്ല, നമ്മൾക്ക് നമ്മളുടെ കാര്യമാണ് വലുത്. Isn't it?
റൈറ്റ്. അത് ഓരോ പേഷ്യന്റും അങ്ങനെ തന്നെയാണ്. അപ്പൊ നമ്മൾ ഓരോ പേഷ്യന്റിന്റെയും ബുദ്ധിമുട്ടിന് അതിൻ്റെ ആയിട്ടുള്ള ആ ഒരു വില നമ്മൾ കൊടുക്കണം, കൽപ്പിക്കണം. നമ്മൾ അവരുടെ പ്രശ്നത്തിന് ഫുൾ കെയർ നമ്മുടെ ഫുൾ ഫോക്കസ് അതാണ് എന്നുള്ള രീതിയിൽ നമുക്ക് അവരെ ബോധ്യപ്പെടുത്തേണ്ടതുണ്ട്. അതിന് ഇങ്ങനത്തെ വാക്കുകൾ ഒരു ഡിസ്റ്റൻസ് ഉണ്ടാകും.
So I think
കമ്പയർ ചെയ്യുന്നതോട് ചിലപ്പോൾ ഡോക്ടർ അത് സമാധാനിപ്പിക്കാൻ നോക്കുന്നതായിരിക്കാം അല്ലേ?
അതാണ് നമ്മുടെ കമ്മ്യൂണിക്കേഷൻ സ്കിൽസ്. Sorry. Sunil, go ahead.
Doctor is trying to give reassurance to the patient, but it doesn't happen like that. അപ്പുറത്തിരിക്കുന്ന ആൾക്ക് they don't feel that they're getting some relief because of that words. So
ഇപ്പോൾ നമ്മള് ഡോക്ടറിന്റെ ഇന്റൻഷനെ ഒരിക്കലും നമ്മൾ ചോദ്യം ചെയ്യും. നമ്മളെല്ലാവരും നല്ല ആൾക്കാർ തന്നെയാണ്, നമ്മളെല്ലാവരും നല്ല ആൾക്കാരും, നമ്മുടെ ഹൃദയം പൊന്നിന്റെ ആണ്, അതെല്ലാം ശരിയാണ്. പക്ഷേ നമ്മൾ ചെയ്യുന്ന കാര്യങ്ങളും പറയുന്ന വാക്കുകളും അതിന് നമുക്ക് മെന്റർഷിപ്പ് ഇല്ലാത്തതുകൊണ്ടാണ് നല്ല ഉദ്ദേശം കൊണ്ട് പറയുന്നത് അതിന് തൃപ്തി ഇല്ലാതെ ആയി വരുന്നത്.
ഇപ്പം ഡയബറ്റീസിനൊക്കെ ഇപ്പൊ ഒറ്റൊരു മെഡിസിനൊക്കെ മാത്രം, ഒരു ടാബ്ലറ്റ്, ഒരു മെറ്റ്ഫോർമിൻ മാത്രം ചിലപ്പോൾ ഒരു സമയമൊക്കെ മാത്രം കഴിക്കുന്ന ആൾക്കാരുണ്ടാവും. എന്നിട്ട് അവർ വന്നിട്ട് പറയും അത്യാവശ്യം അത് തന്നെ കഴിക്കാൻ വയ്യാണ്ടൊക്കെ ഉണ്ടാവും. പക്ഷെ അത് കഴിച്ചാൽ കൺട്രോൾ ആവുന്നതൊക്കെ തന്നെ ആയിരിക്കും. പക്ഷെ ഇതുപോലെ പ്രഷറോ അങ്ങനെയൊക്കെ ഒരുപാട് മെഡിസിൻസും കഴിച്ചിട്ടും കൺട്രോൾ ആവാത്തവരുണ്ടാവും. അപ്പൊ ഈ ചെറിയ ഒറ്റൊരു ടാബ്ലറ്റ് ഒക്കെ കഴിച്ചിട്ട് കൺട്രോൾ ആവാത്തവർ വരുമ്പം കഴിക്കാൻ മടിയാന്നൊക്കെ പറയുമ്പോൾ നമ്മൾ ചിലപ്പോൾ അറിയാണ്ട് പറഞ്ഞു. ഓരോരുത്തരാണെങ്കിൽ കഴിച്ചിട്ട് പോലും കൺട്രോൾ ആവുന്നില്ല, നിങ്ങൾക്ക് ഇതെങ്കിലും കഴിച്ചൂടെ എന്ന് അറിയാൻ ചിലപ്പോൾ പറഞ്ഞു പോലുണ്ട്. കമ്പയർ ചെയ്യുന്ന പോലെ ചിലപ്പോ.
Okay, so you can do another thing. Actually, you should not do that. You can ask the patient to mingle with the other patient who is taking multiple medication, and then they should talk to each other, and then the patient who came to you should understand that okay, he is taking so much medication and he is not getting control, but I am not taking anything and it is out of control. If I take one medicine, it will get under control. That should be come from the patient itself by comparing with the another person. We can't compare with one person with another person. That patient himself should understand.
ഒരു അഡീഷണൽ പോയിന്റ്, ഈ പേഷ്യന്റ് എന്തുകൊണ്ട് അങ്ങനെ റെഗുലർ ആയിട്ട് കഴിക്കാൻ കൂട്ടാക്കണില്ല എന്നൊന്നും അന്വേഷിക്കേണ്ടില്ല. അവർക്ക് എന്താണ് ബുദ്ധിമുട്ട്, ചിലപ്പോ എന്തെങ്കിലും ബുദ്ധിമുട്ട് ഉണ്ടായിരിക്കാം, നമുക്ക് അറിഞ്ഞൂടാ. അപ്പൊ ഒരു കംപ്ലയൻസ് ശരിയാവണില്ലെങ്കിൽ അതിന്റെ പിന്നിൽ കാരണം എന്താണെന്നും കൂടി ഒന്ന് അന്വേഷിക്കേണ്ടിയിരിക്കും.
ഈ പ്രഷറിന്റെ ഒക്കെ മരുന്ന് കഴിച്ചു തുടങ്ങുന്ന ആൾക്കാർക്ക് അവർ തുടങ്ങും മെഡിസിൻ പ്രിസ്ക്രൈബ് നമ്മൾ സ്റ്റാർട്ട് ചെയ്യുമ്പോഴേക്കും മിക്കവാറുള്ള ചോദ്യമായിരിക്കും, ഇതിപ്പോ തുടങ്ങിയാൽ ഞാൻ ഇനി ജീവിതകാലം ഫുള്ള് കഴിക്കണ്ടേ, അതുകൊണ്ട് കഴിക്കാൻ തുടങ്ങാൻ വയ്യ, കഴിക്കണ്ടെന്നുള്ളത് അങ്ങനെ ഒരു ആറ്റിറ്റ്യൂഡിൽ വരുന്നതായിരിക്കും.
കറക്റ്റ്. അപ്പോ ഇപ്പൊ നമ്മുടെ വർക്കിംഗ് എൻവയറമെന്റ്, ഇപ്പൊ നമ്മൾ ഒരു ദിവസം 100 പേഷ്യൻസിനെ കാണുന്നതാണെങ്കിൽ ഒരു പക്ഷെ ഇത് ഈ പറഞ്ഞ പോലെ ഇതെന്താണ് കാരണം എന്ന് നമുക്ക് വിശദമായിട്ട് പറഞ്ഞു കൊടുക്കാൻ ചിലപ്പോൾ ബുദ്ധിമുട്ടായിരിക്കും. പക്ഷെ നമ്മുടെ അതേ ക്ലിനിക്കിൽ പ്രഷർ കൂടിയിട്ട് അതിന്റെ പ്രശ്നം മൂലം ഉള്ളൊരു രോഗിയെ, നമ്മുടെ ഡോക്ടർ സുനിൽ പറഞ്ഞ പോലെ അങ്ങനെ ഒരു രോഗിയെ കാണിച്ചു കൊടുത്താൽ കണ്ണുകൊണ്ട് അതിന്റെ ഭവിഷ്യത്വം കാണാൻ പറ്റുമെങ്കിൽ പെട്ടെന്ന് പഠിക്കാൻ പറ്റും. റൈറ്റ്. അപ്പൊ അങ്ങനത്തെ ഒരു വളരെ ഹൈ പ്രഷർ ഹോസ്പിറ്റൽ അല്ലെങ്കിൽ വർക്ക് എൻവയറമെന്റിൽ വർക്ക് ചെയ്യുകയാണെങ്കിൽ എല്ലാം നമ്മൾ ഒരു ലെക്ചർ എടുക്കേണ്ട ആവശ്യമില്ല, പലതും എക്സാമ്പിൾസ് ആയിട്ട് കാണിച്ചു കൊടുക്കാൻ പറ്റും. ഇദ്ദേഹം പ്രഷറിന്റെ മരുന്ന് കറക്റ്റ് ആയിട്ട് കഴിക്കാതെ ഇപ്പതായി അവസ്ഥയിലാണ്, ഈ ഒരു വശം അനങ്ങാതെ ഇരിക്കുന്നു, ഇത് ഒരു സാധ്യതയാണ്, നിങ്ങൾക്കത് വരാതിരിക്കാൻ വേണ്ടിയാണ് ഞാനിത് പറയുന്നത് എന്നുള്ള രീതിയിൽ വളരെ നല്ല രീതിയിൽ അങ്ങനെ നമുക്ക് പറഞ്ഞു കൊടുക്കാനും പറ്റും, ചൂണ്ടിക്കാണിക്കാനും പറ്റും. നേരെ മറിച്ച് നമുക്ക് ഇത്രയും കൂടി റിലാക്സ്ഡ് ആയിട്ടുള്ള ഒരു വർക്ക് എൻവയറമെന്റിൽ വർക്ക് ചെയ്യണമെങ്കിൽ ഇപ്പൊ ഇന്നത്തെ കാലത്ത് നമുക്ക് നമ്മുടെ മൊബൈൽ ഫോണിൽ ഗൂഗിളും ഇമേജസ് എല്ലാം കിട്ടും അല്ലെ. കോൺസിക്വൻസസ് ഓഫ് ഹൈപ്പർ ടെൻഷൻ എന്ന് പറഞ്ഞ് 2-3 ഇമേജ് കാണിച്ചു കൊടുക്കുക. ആർട്ടിക്കിൾസ്, സ്കോളർലി ആർട്ടിക്കിൾസ് അല്ല, 2-3 ഇമേജസ് കാണിച്ചു കൊടുക്കുക. ഇമേജസ് ആർ വർത്ത് 1000 വേർഡ്സ്, പിക്ചേഴ്സ് ആർ വർത്ത് 1000 വേർഡ്സ്. അങ്ങനെ നമ്മുടെ പബ്ലിക്കിന് അങ്ങനത്തെ ചില രീതിയിൽ നമുക്ക് അവർക്ക് കാണിച്ചു കൊടുക്കാൻ പറ്റും. ഇപ്പൊ പലപ്പോഴും ഞാൻ എൻ്റെ മൊബൈൽ ഫോണിൽ എന്താ പറയാ പല ആവശ്യത്തിനും ഇമേജസ് കാണിച്ചു കൊടുത്തിട്ട് ഒരു ഇൻസ്റ്റന്റ് എഡ്യൂക്കേഷൻ ആണ് ചെയ്യുന്നത്. നമുക്ക് ടെക്നോളജി ഉപയോഗിക്കണം, ടെക്നോളജി ഉപയോഗിക്കാൻ ഉള്ളത് തന്നെയാണ്.
Anybody else? Any more questions? Amala? Yeah.
Hello.
Yes, Amala.
How do we communicate? How do we communicate with an angry relative? Anger is not something we can communicate. How do we do that?
Sorry, you are not very much audible. Did you hear what?
Hello.
Yes.
Hello.
Yes, Amala.
Can you repeat the question?
I was asking, how can we communicate? Yes. How can we communicate with an angry relative? Anger is not something we can. It's an emotion we cannot deal with.
Okay. Biju? Okay. She was asking, how can we communicate with an angry relative? I think you can take 5 minutes and give a gist of what we need to.
Oh, okay. Managing anger again is a workshop in itself, at least half a day workshop. The basic thing is uh, we have to ensure that we don't increase somebody's anger by either confronting them or ignoring them. Many a times when we give them excuses or we try to reason with people, then it turns out to be a confrontation. And somebody who's very, very angry, even if he apologizes, that also becomes something that increases anger. Similarly, if we are afraid and we are not able to speak properly, that also increases the anger. If you just stay silent, that also increases anger. So it's very important to neither ignore the situation nor to confront the situation. Both things will increase the anger. And the gist of the matter is we have to when somebody is very angry, and if you are sitting, get up, because it's very important to keep the both bodies in same position. So stand up when somebody's come over and getting very angry, and stand in a respectful posture. There are ways of standing in respectful posture. Make eye contact, but no staring. And when they are speaking very angrily to you, just stand respectfully and shake your head as you would if you're listening attentively to somebody. And in this way, you are neither confronting them because you're not saying anything. Similarly, you are not ignoring them because you're making eye contact and standing there. And when you stand, you're also claiming that I'm not afraid of you. But when you stand respectfully, you're also saying that I am not threatening you. So there has to be this fine balance. Of course, in the workshop, I teach how to do that. But the gist of the matter is stand respectfully, make eye contact, and shake your head, listen to them. And this will help the person who's angry to ventilate their anger. Because when somebody is in high emotion, they are not open to reasonable conversation. Right? Then intellectual conversation cannot happen if you're in a very high state of emotion. So when somebody's in anger, we have to ventilate the anger, allow the person to speak and ventilate the anger. And once the person calms down, then you can ask them, I want to know more about this. Can we sit and talk? Only then get both parties, yourself and the person who's angry, to sit down and then listen to them. Active listening is a skill. And once that happens, usually most of the anger drains out, and then you can have an actual conversation as to what exactly got him angry and what can be done about it and what cannot be done about it. That is the way we go about dealing with an angry person. Now, remember, This is what we do in a case of clinical anger. That is an anger in a clinical environment. This is no way you deal with somebody, this is no way you deal with somebody who's under the influence of alcohol or drugs. And definitely this is not the way you deal with an angry mob. If there's an angry mob, run for your life, and don't stand there and shake your head. And let the security people or people who know how to deal with law and order take care of it. This method that I talked to you about is how you deal with somebody who's getting angry outside your OP or inside your ward, and we have to diffuse it very fast before it becomes a major issue. I hope that.
Yeah.
No, Sunil, if you'll excuse me, I need to, as I said earlier, I need to go. I am sorry, I had this important meeting with, I have an important meeting to attend to. So I wish you all of you good luck. I hope, Sunil, you will take over from here.
Okay, thank you, Biju. And we can see on next Tuesday.
Yes. Okay then. Bye-bye.
Okay. So let's move on to patient story. And Dr. Kurian will be presenting. Okay. 1 minute. Okay, Dr. Kurian.
Good evening, sir. Can you hear me?
Yes.
Okay, today I'm presenting a case of buccal mucosa carcinoma of a 62-year-old male. Next slide, please. The patient came with chief complaints of oral fistula and maggots in situ. His history of preceding illness was 62-year-old Mr. H was a known beetle neck chewer hailing from a nearby area and was apparently had no complaints before 2016. Later, he developed pain in the right buccal mucosa associated with a swelling about the size of 2 centimeters. Past history, he had undergone cataract surgery 10 years back and right inguinal hernia surgery for 3 years back. Has a significant family history of his brother having carcinoma tongue, and he expired 10 years back. He had a history of chewing tobacco for last 30 years, which was stopped 10 years back. On examination, he had severe trismus and ulcer on the right buccal mucosa from the first premolar extending to the retromandibular joint. The tongue palate was normal and the neck nodes was not palpable. The ulcer was progressively increasing in size. He went to the NT-OPD in a tertiary center in November 2016. The assessment was done, a punch biopsy was taken and sent for histological examination, where he was diagnosed as a squamous cell carcinoma of buccal mucosa. The investigations done was normal. Chest X-ray was taken, which was normal, and contrast sensitive CT was taken, which indicated the lesion was about 3 centimeters by 3.4 centimeters, and tissue lesion could be seen. The biopsy showed squamous cell carcinoma, and complete hemogram and blood grouping and liver function and renal function test was taken as per hospital requirements. The treatment given was he was given 35 cycles of radiotherapy was given from Jan to April. The ulcerative growth over the right mucosa became became more ulcerative from the right cheek, forming a orocutaneous fistula. The patient was progressed. His cancer was progressed to T4. As the tumor was inoperable, he was admitted in the palliative care ward in another tertiary center and was treated with Ryle's tube feeding. Rice tube feeding was given to him, high protein diet, and dressing of the wound with adequate analgesic tablets. Morphine was given, and later debridement of the orocutaneous fistula was done. He was planned for a gingivitis for feeding, but the patient refused. The psychological issues the patient was facing was he had the only daughter who was yet to get married, so he was very anxious whether his daughter's marriage would take place. Um, there was nobody else to take care about, nobody else to take care of his family other than him. His son was abroad, and he was actually getting money from the son. He was not very happy about it. He wanted to live his life like he wanted to be the supporting man of the family. Um, and his wife was not able to do all her work alone. He was also anxious anxious about his death. The doctor had informed him that he may not have a life expectancy, have a long life expectancy. So he wanted to get her daughter married before something bad happened. Next slide, please. The communication issues was the patient had edema over the face, which was difficult, which made him difficult to communicate. With the nasogastric tube, it was difficult for him to talk properly. First, he was little angry. He was angry about it. Later, he started writing things to communicate. But later again, he started learning sign language for communicating. The family wanted him to be alive till his daughter's marriage. And at the point of time, his family was getting upset and was not really accepting the reality of the situation. There was no communication issues with the doctor teams. The treatment given to the patient was syrup lactulose 30 ml was given thrice a day. Pain was treated with tablet morphine. Cleaning and dressing with turpentine oil was done to avoid maggots. And for avoiding the foul smelling lesion, tablet metrogel was given in the dressing, and adequate nutrition was given for the patient. The outcomes, the patient actually came with the palliative actually to the surgical OP with about 200 to 300 maggots, which had severe foul smelling. It was a severe foul smelling lesions. So the patient had to be. There was no separate room for keeping the patient. So it was difficult for the bystanders and even for the other patient. So they had to debride the whole wound, and they had to use agarbattis and room fresheners for the patient. The patient's pain was managed with morphine 10 mg 4th hourly and 20 mg HS. The patient later slowly started getting improved. Improvement was noted with the patient. The patient was given nasogastric for the feeding. Nasogastric tube was used for the feeding, and the patient's bystander was given adequate training for feeding through the nasogastric tube. Later he was discharged for her. Later he was discharged once he came to the OPD. Actually, later he was discharged once his physical condition was good. He came with the OPD for actually inviting for his daughter's wedding, and also for changing the nasogastric tube and to collect more pain-relieving tablets. He was actually able to fulfill his wishes by marrying her daughter. The marriage was organized and planned. He came to the hospital once again with severe complaints of headache, which was treated symptomatically with paracetamol SOS. The team which consulted the patient included the surgical oncologist who discussed about the feeding gynostomy, but the patient was not willing for undergoing another surgery. Palliative care physician was managing his pain. The dietitian was required for balancing his diet because he could not take solid diet. Counselor access was being given for his psychological issues and to counsel his families. Palliative care nurses had to support him for his wound, to clean his wound. The ethical issues was initially there was initial answering questions from his family regarding the assurance of his well-being, whether he'll be alive before till his marriage, till his daughter's marriage was difficult. Support has to be given. Whether where we could not give appropriate answer for his question. It was uncertain whether he would be alive till that date. The palliative care ward, it was difficult to manage him with the palliative care ward as there was a foul smelling lesion that he had. So it was difficult for convincing the other patient also to be in the same ward. So in the future, we had to create awareness regarding the cancer wound. Next slide. The summary, we had to physical summary. In the summary of managing this patient, we had to meet his nutritional requirement, and we had to maintain as adequate treatment for the pain management. Psychological issues, there was a orocutaneous fistula with maggots he was having, and there was a newlywed couple was coming to his house with his son-in-law. So it was difficult to convince the whole family about the situation. Also, having a new member in this house, it was difficult to communicate about the same situation to his son-in-law. Next patient. Next. There was always the social stigma was there against this patient because he was already a tobacco smoker for 30 years. Later, he developed this cancer, even though his brother was also having the cancer. Still, he was also actually the causative factor was the same for both of them. So when also in spiritual aspects, the patient always had a feeling that why this God had made him suffer. Actually, he had quitted smoking sometime before, but later he had developed the symptoms. So he is always used to blame himself for his situations. Though it was late to stop his bad habit, but he had already stopped it. Next slide. So, discussion points are how in such patient where you cannot orally feed the patient, how to give the nutrition supplement for the patient, how to assess how much nutrition has to be given to the patient, how often we have to change this nasogastric tube, how can we communicate the patient about his life expectancy. If the patient is in nasogastric tube and the patient was not willing to continue in the nasogastric tube, how to go forward about it, and how to counsel the patient about how to take care him in the home stay.
So thank you, Dr. Kurian. Before going on to discussion, are you doing any course in palliative care?
No, sir.
Because I see that it has been very the framework of the presentation was very good, and this framework. Yeah.
I went to a palliative care center in Mahatma Gandhi College and got this patient, sir.
Yeah. Okay. So thank you. Anybody want to offer any answer for how can we take care about the nutritional needs of the patient like this? Anybody? Krishna?
Hello.
Yes, Krishna.
Hello, sir. Actually, in this patient, we have this orocutaneous fistula and all.
Yes.
So, I think the nutritional needs can be made by parenteral nutrition techniques, because enteral nutrition will be difficult for the patient, and but Riles tube feeding was then. But in a hospital setup, I think this parenteral nutrition can be better than Riles tube feeding.
Okay. Parenteral means it is anything other than enteral route. Okay, anything other than enteral route. So enteral means that we take usually through mouth orally. So that's known as enteral. Anything else is known as parenteral. So it may be right tube feeding, or it may be through a venous access, or it may be some surgically created ostomies like PEC or feeding jejunostomy. So there are many options, but the question is, before going on to the how to take care of nutrition needs, or before moving on to the parenteral route, we should see when we do some um, uh, parenteral route, then we have to weigh the balance between whether are we going to give any beneficence for the patient by feeding this patient. Maybe in a terminally ill patient, maybe the patient has only 1 month to live. In such patients, creating a PEC, that is percutaneous endoscopic gastrostomy, would not be good. And we also need to look into the resources. That is, I am talking about the ethical points of nutritional, artificial nutrition. Okay. So the so you have to look, first of all you have to see what does the patient want, then you have to weigh the balance between the beneficence and non-maleficence, and what is the economical status of the patient. So after that, you have to see, uh, even the autonomy of the caregiver need to be respected. So after this, you can decide whether to go for any artificial nutrition or not. So artificial, Krishnamar has come. No, sorry. Krishnamar, what I meant was artificial nutrition, not parenteral nutrition. So artificial nutrition includes many methods like parenteral, nasogastric tube, feeding jejunostomy, gastrostomy, etc. All these things. So, in this patient, is he still alive, Dr. Puri? Yes?
Yes, sir.
Okay. So, this patient was supposed to have a short lifespan as per your patient story, as your presentation, but it seems that he lived for another 2 years. So this can happen. So we can't decide whether to continue for artificial nutrition or not. But we have to see the prognosis of the patient. That's the most important point. And you have to also take into consideration the ethical framework before deciding what type of artificial nutrition is needed for this patient. As this patient had orocutaneous fistula, as Dr. Krishnamar told, oral nutrition will not be enough. But if this patient, if I have seen him, and if I think that okay, this patient is terminal, I would not have gone for any artificial nutrition. I will talk to the family, and then family and patient, and will reach at a consensus. That's what we usually do. So there are many types of artificial nutrition that can be used to take care of nutritional needs of patients with uh, oral problems. But I think in our circumstances, the major problem would be financial status of the patient. Dr. Kurin,
Yes, sir.
do you want to comment on anything about that?
No, sir. No, sir. Actually, this artificial food, in the sense we have to give. There are special supplements, sir.
Yeah.
Okay, sir.
And there are many types of supplements are available, but that also what I am saying is you can give all the supplements, but you have to see the prognosis of the patient and also the financial status of the patient before going for any types of artificial nutrition.
Sir, like if the patient is telling like I don't want to be in this nasogastrical tube for a longer time, so when will we actually take it out, sir? Like we can just when what moment we have to make a decision that we have to relieve the patient from the nasogastric tube, sir?
Okay. So in a patient who is going, there are many patients with head and neck malignancies who usually need a nasogastric tube. But maybe some of them, after taking radiotherapy and types of curative treatment, they will be able to take orally. Maybe after a couple of months, we will ask the patient to try take something orally, and if it is possible for the patient, then we can take it up. But in case of patients who are whose general condition is gradually deteriorating, and we see that this patient is going to be terminal, and the patient requests that I know that my condition is very bad, and by feeding you are not going to get anything out of this. And if they express that wish, then I think it can be taken out, because the patient knows uh, about what is happening to him, and professionals also understand that by feeding alone, this patient uh, will not survive. So I would tell you something. Um, ഇത്തിൽക്കണ്ണി ഇല്ലേ, what we usually talk to the patient and family. ഇത്തിൽക്കണ്ണി എന്താണെന്നറിയോ? മരത്തുമ്മ കയറുന്ന പാരസൈറ്റ് പ്ലാന്റ് ഇത്തിൽക്കണ്ണി. സോ നമ്മൾ സാധാരണ പേഷ്യൻസിന്റെ അടുത്ത് പറയുന്നത്, പേഷ്യൻസ് അല്ലെങ്കിൽ ഫാമിലിക്കാണ് അത് കൂടുതൽ കൺസേൺ ആയിട്ട് വരിക. ഭക്ഷണം കഴിക്കുന്നില്ല, നോട്ട് ഈറ്റിംഗ് എനിത്തിങ്. യൂഷ്വലി ദ പേഷ്യന്റ് വിൽ ബി വെരി nearing end of life. So that's where the patient usually don't take, or they decrease the intake. നമ്മൾ പേഷ്യൻ്റെ അടുത്ത് പറയുന്നത് എങ്ങനെയാണ്, ഇപ്പോൾ ഒരു മാവ്, ആ മാവിന്ന് ഒരു ഇത്തിൽക്കണ്ണി കയറുന്നു. In the beginning, and there is no problem for the mango tree, but when the itilkanni becomes grow and it spreads all over the mango tree, then എന്ത് സംഭവിക്കും? മാവ് ഉണങ്ങും, പക്ഷെ ഇത്തിൽക്കണ്ണി എന്നാലും പടർന്ന് പന്തലിക്കും. ഈ സമയത്ത് നമ്മൾ കുറച്ച് വളം കൊണ്ടുപോയി മാവിന്റെ കടയ്ക്ക് വെച്ചതുകൊണ്ട് പ്രത്യേകിച്ച് ബെനിഫിറ്റ് ഒന്നും മാവിന് കിട്ടാൻ പോകുന്നില്ല, പക്ഷെ ഇത്തിൽക്കണ്ണി അത് വലിച്ച് വലുതാവും. So this is what actually happens. നമ്മൾ ഭക്ഷണം കഴിക്കുന്നുണ്ടെങ്കിലും most of the energy is utilized by the cancer cells. Normal cells utilizes less energy. So it is not going to get benefit for the patient.
Thank you, sir. Thank you, sir.
And how often do we need to change nasogastric tube? I think all of you are working in many hospitals. What is your hospital policy? Jyoti? She got disconnected, I think. No, she's there. Jyoti, what is your hospital policy? Or anybody else, if you have a hospital policy of how frequently we need to change rails tube? Okay, Kunien, do you have an answer for that?
No, sir, I don't have an answer.
Okay. So I searched the literature and I couldn't find out anything on this, how frequently should we change the rails tube. But in one article I saw that in 4 to 6 weeks you need to change the rails tube. But as I understand, there is the palliative care centers across Kerala, and I think as palliative care community, they usually change the Riles tube when it is when the Riles tube gets dislodged or it gets blocked. Otherwise, it is usually kept for a long time. So we also do the same. We usually don't change the Riles tube very frequently. So I think it will be depending on the hospital policy. Some patients will come to us and tell us that that doctor has told us to change it 2 monthly or 3 monthly. So it is depending on the hospital policy. How can we communicate the patient's life expectancy to the patient? Kurian, what did you actually mean? Is it the method of telling how much do you live, or is it something else that you intended to ask?
Very enthusiastic to get his wife, daughter married. So the doctor, like the patient would be asking the doctor, like how long will be he living. So
Okay.
how to actually.
Okay, I understand. So this is a very common situation that we face every day. So today also one of the patient's wife asked me. So anybody has any answers for Dr. Kurian's question? Anybody? Krishna?
ഹലോ
Yes.
സർ, ഞാൻ മലയാളത്തിൽ പറയാം.
Right.
നമുക്കിപ്പോ ബേസിക്കലി ഈ പേഷ്യന്റിന്റെ കണ്ടീഷനെ പറ്റിയും അയാൾക്കുണ്ടാവുന്ന ഡിസീസിനെ പറ്റിയും അയാൾക്ക് ഒരു പെർസെപ്ഷൻ ഉണ്ടായിരിക്കുമല്ലോ സർ.
Okay.
അപ്പോൾ ഫസ്റ്റ് നമ്മൾ അവരുമായിട്ട് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുമ്പോൾ അവർക്ക് ആ ഡിസീസിനെ പറ്റിയുള്ള അവരുടെ പെർസെപ്ഷൻ അല്ലെങ്കിൽ അവരുടെ ഫ്യൂച്ചർ എങ്ങനെയായിരിക്കും എന്നുള്ള അവരുടെ അണ്ടർസ്റ്റാൻഡിങ് ആദ്യം ഒന്ന് ഇങ്ങോട്ട് പറയിച്ചിട്ട് ലേറ്റർ അതിനകത്ത് നമുക്ക് ചേഞ്ചസ് വരുത്തി തിരിച്ചവർക്ക് പറഞ്ഞു കൊടുത്താൽ.
Okay, so that's very important. Finding out the insight of the person who is asking that. അത് കഴിഞ്ഞിട്ട് നമുക്ക്, as Dr. Krishna told, we have to fill in the gaps. പക്ഷേ അതിനേക്കാളും മുമ്പ് what we have to do is, if anybody is asking how long I will live, usually there will be something behind that question. So in this patient, if this patient had asked that question, maybe because he wanted to know when should my daughter get married. I said, do I have a long time to see the marriage? That may be the reason. So first of all, we have to understand there is a question behind this question. So we have to explore why are you asking that question. That's very important. And next step is, as you told, we have to find out the insight about the disease and ask the patient, what do you think? How long will you live? So the patient may not tell anything or may tell something. Then I think you don't need to give some dates or days, like you will live only for, or you will live for 6 months, or no, it is not usually like that. നമ്മൾ usually പറയുന്നത്, because if you give some dates or months, then the patient will be looking at the calendar each day, and as the date approaches they will be very anxious, and even before the actual death happens, because of the anxiety they are going to die. So don't give any dates or months like that. What you can tell is, suppose the patient is deteriorating by taking months, then we will tell that you have months to live. Months to live. We are not specifying how many months. Okay, you have months to live. Or if the patient is deteriorating by weeks, it is usually said that you have only weeks to live. And if it is days, you have only days to live. This is the usual thing that is usually told to the patient. But there are many progress in the life in estimating life expectancy of the patient. There are many tools available, and even in the you can get internet-based tools. You have to just enter the age, and there are certain parameters that they require, and you will get the life expectancy. And there are many other tools which are available like palliative performance scale. There are many tools which also predicts the possibility of life expectancy. So these are certain tools which are available for predicting the life expectancy. So most important thing is we are not giving any dates or day for the patient. But if there is something like this patient case that his daughter need to get married, then we will encourage the patient to get it happen as early as possible if we feel that the patient's prognosis is poor. Any comments? Any comments from anybody? Dr. Kurian? Please unmute Dr. Kurian. Yeah, we didn't hear Dr. Kurian.
No, sir, nothing, sir. Thank you, sir. Thank you, sir.
So in a conscious patient like him, if his life is dependent on supportive system, and when the patient asks to discontinue, saying how to respond. I think we already answered this question.
Yes, sir. Yes, sir.
How
Yes,
can
sir, we have discussed. We have discussed this, sir.
Yeah. How can we counsel the patient bystanders regarding his health care during his home stay? Are you talking about this patient has gone to his home, and when we visit the patient at his home during our home care, how do we communicate? Is that you?
Yes, sir. Actually, the patient had gone home. He was only coming to the palliative care for changing his Riles tube, and if unless and until he doesn't have any other complaint, he doesn't turn up to the hospital, sir.
Okay. So I think the problem with this is we have to get hold of the decision makers, because in each patient's with each patient there will be sometimes there will be one decision maker or there will be many decision makers. So we have to get hold of decision makers, and we have to talk to them regarding what is happening and what do you think. You can actually say that okay, this is what I think, but uh, I also have uncertainties that you can openly tell the patient and family, even in communicating the life expectancy. നമ്മൾ സാധാരണ പറയാ ഇങ്ങനെയാണ് നമുക്ക് തോന്നുന്നത്, പക്ഷെ നമ്മളല്ല ഇത് നിശ്ചയിക്കുന്നത്, ഇത് നമ്മളുടെ കൈകളിലല്ല എന്ന് നമുക്ക് പറയാം. കാരണം we are also helpless because we can't predict the time of death very accurately. But if the patient is near end of life, then you can predict the time of death more accurately. Kurian? Yes, Dr. Kurian.
Thank you, sir. Thank you, sir.
Anybody else have any comments? Jyoti, Nihita, Krishnakumar, Sapna, Srida, Malo. So, shall we stop for today? Yes. Jyoti, want to speak? Okay, we can't hear anything, Jyoti. So let's close this session, and we will meet on next Tuesday. Thank you all
With
for
the same
joining.
topic, communication, I will send you the feedback in the group chat. Please log in and give feedback for this class. It has been a very interactive class, and we like to proceed with the same. Thank you all for joining. See you on Tuesday.
Okay,
Bye.
bye.